Can we bring in Dr. Ornish? Is Dr. Ornish with us? There he is. Hi, Dean.
Hey, Neal. How are you, my friend?
So great to see you. Thank you for joining us. I have to say,
I apologize. You're always so elegantly dressed. I'm on our week-long annual family vacation, and because of my love for you and the respect we're doing, I wanted to be here, even if only virtually. And also because you're my elder. You know, you turned 70 on July 10th. I turned 76 days later, so I have to respect you because you're my elder. And it's such an auspicious time. I really can't think of anything better than to be having this dialogue with you today.
well, Dean, I want to say that I think your lifespan is probably going to be about 140 years, so I'd say you're just now middle-aged.
Thank you.
We're going to open the microphones to questions in a little bit because I know there are many questions for you, but I want to talk with you first about a number of things, if you don't mind. And one of the first things I would like to talk to you about is kind of the most current challenge you're dealing with. You have launched an incredible study on Alzheimer's disease, and are there things that diet and lifestyle can do? Now, I'm not going to ask you to divulge the results because my understanding is that's in the publication process, but I do want to ask, what is it that gave you the idea that diet and lifestyle might really be helpful, and also how you chose the diet and lifestyle that would matter?
Yeah, thank you. Well, as you say, I think when you lose your memories, you lose everything. And unlike heart disease or type 2 diabetes or prostate cancer or other common chronic diseases, whether other treatments, whether surgical or medical, that have value, nothing really works that well with Alzheimer's. You know, there have only been 2 drugs approved in the last 20 years. One, aducanumab, probably should have never been approved 3 or so years ago. And more recently, lecanemab, a cousin of it, at best slows down the rate at which you get worse by 27% or so. But it's extremely expensive. It's $26,000 per person per year. But when you add in the other costs of PET scans and infusions and so on, it's closer to $100,000 per person per year. And a significant number of people have side effects like, you know, brain hemorrhages and brain swelling and so on. So it's not great what we have. So I thought, gosh, you know, Alzheimer's runs in my family. My mom died of it, all of her siblings. I have one of the ApoE4 genes, so I'm at risk for it. So it's personally meaningful for me as well. And my mom was a true genius, and just, you know, she graduated high school when she was 14. She got her master's degree in journalism from Northwestern when she was, I think, 17 or so, the youngest person at the time. And just watching her beautiful mind decay was, like it is for anybody who has Alzheimer's in their family, which is increasingly common, was heartbreaking. But I also knew that what's good for your heart is good for your brain. Alzheimer's and heart disease share a lot of the same underlying biological mechanisms. Just that was really the basis for the book that my wife Ann and I wrote. We've worked together now for 28 years, called Undo It. And it puts forth what I think was a radically simple unifying theory. Like, why is it that with all this interest in personalized medicine, which properly used, you know, if you have breast cancer, knowing the cell type and the estrogen receptor status and the HER2 positive or negative status and so on, can really tailor treatments. But in a larger context, why is it that the same lifestyle changes that we found over doing research now for 45 years could stop and often reverse the progression of so many different diseases? You know, I was trained like you were to view heart disease and type 2 diabetes and high blood pressure, high cholesterol, prostate cancer, and Alzheimer's as being fundamentally different diseases, different diagnoses, different treatments. And yet, over many years of doing studies, we found that these same lifestyle changes could beneficially affect all of them and often reverse them. You know, a whole foods, plant-based diet, low in fat and sugar, mostly fruits, vegetables, whole grains, legumes, soy products as they come in nature, moderate exercise, both aerobic and strength training, meditation and other yoga-based stress management, which are really more than stress management, which we can talk about later if you want, and support groups, you know, and again, support groups not just to help people stay on the diet, but as a powerful intervention in its own right, which we can also talk about later, the epidemic of loneliness and depression that is really now becoming pandemic, or to reduce it to its essence, to eat well, move more, stress less, and love more. Why is it that these same lifestyle changes could affect so many different diseases? And the answer is that they're really not as different as we thought. They all share the same underlying biological mechanisms, things like things you're familiar with: chronic inflammation, oxidative stress, changes in the microbiome, the 100 trillion cells that live in our gut, and telomeres, in gene expression, and angiogenesis, and immune function, and overstimulation of the sympathetic nervous system, and so on. And each one of these mechanisms, in turn, is directly influenced by what we eat, how we respond to stress, how much exercise we get, and how much love and support we have. So I thought, it reminded me very much when I started thinking about doing research on Alzheimer's 5 or 6 years ago, of where we were with heart disease in 1977, when I was a second-year medical student and did my first research. In other words, at the time, back in 1977, it was thought once you had heart disease, the best you could do was to slow down the rate at which you got worse. But we found that when people made more intensive changes, and they changed a lot of lifestyle factors at the same time, that heart disease could often be reversed. And there was the first study in a randomized trial showing that. And I think these findings, it also taught me the value of doing research that, properly done, with the leading investigators and published in first-year peer-reviewed journals, can redefine what's possible for people, and such can give many people new hope and new choices that they didn't have before. And so what people think about Alzheimer's today is what they thought about heart disease then, that the best you could do is to slow down the rate at which you get worse. Ounce of prevention, pound of cure, if you will. And so my hypothesis, or so the unifying theory in the Undo It book was that because all these biological mechanisms share the same, all these chronic diseases share the same underlying biological mechanisms, you don't have to necessarily personalize as much. Lifestyle changes, eat well, move more, stress less, love more, perhaps they could affect the progression of early stage Alzheimer's. And when I reviewed the literature, when you looked at the landmark finger study that Mia Kivipelto did from the Karolinska Institute, finger is an acronym for Finnish Intensive Something Something Study. It was basically what Dr. Kivipelto calls a multimodal intervention, a less intensive version, if you will, of what we were doing. And she found in working with people who had early dementia that it slowed the rate, or who had risk for dementia, that it slowed the rate of people becoming demented. Not so different from what the MIND study report recently looked at, and found that it did slow the rate of getting worse. And that made headlines worldwide, as it should have. And it, again, was just one more element of thinking, well, gosh, if Alzheimer's and heart disease and these other conditions, these chronic illnesses share the same biological mechanisms, which are all lifestyle related, and we know that more moderate lifestyle changes can help prevent or slow the rate of progression into dementia, and even with people who have Alzheimer's may slow the rate of getting worse. Maybe more intensive ones might stop or reverse it. And if it could, and I'm just saying if at this point, if that were true, that could give millions of people new hope and new choices in the area that really matters most for reasons we've talked about. So I figured whatever we showed, if we did it properly, it would be important. If we showed it did nothing, that'd be really disappointing, but people need to know that so they don't fool themselves. If we showed that we could stop or reverse it as well or better than drugs at a fraction of the cost, and with the only side effects being good ones, like your heart disease gets better and your cholesterol and blood pressure and so on, that would be a really important finding. So in some ways it's the most difficult study that we've ever done, but it's also potentially the most meaningful.
Now tell me about the endpoints that you're looking at. How do you track how had you tracked in your study how the participants were doing?
We're using the same endpoint measures that are used in the FDA drug trials. There are different measures of cognitive function. None of them are particularly great. They all have a lot of variability in them, which makes it harder to show statistically significant differences, especially in a small study. But they're the ones we're using, and because again, that's considered the state of the art. We're also looking at a variety of biomarkers, things like the A-beta 42/40 ratio of amyloid and changes. I mean, just literally hundreds of biomarkers we're looking at now to look at measures of inflammation, of amyloid, of tau, of some of the neurofibrillatory biomarkers, as well as things like insulin levels and C-reactive protein and the usual suspects. And I think looking at the biomarkers will add more biological plausibility to our findings if we can show, and then if we can also correlate changes in biomarkers with changes in cognitive function, it may give us more insight if some people do get better, which ones do and why, being more predictive about that. And the other thing about would be great is if we were able to show that we could stop or reverse the progression of Alzheimer's. It could also be a game changer from the standpoint of prevention. There are more and more biological blood tests, for example, that can tell you 10 and even 20 years earlier whether or not you're at risk for Alzheimer's disease. Even the ApoE4 marker, a lot of people don't even want to know. They say, like, why would I want to know if I'm at risk for getting something so horrible if I can't do anything about it? So if we were to show, or others would show, that you can do something about it, then hopefully that might encourage people to find out earlier if they're at risk for it before it becomes clinically apparent. And certainly the earlier, I think everyone agrees that you can intervene with Alzheimer's, whether it's through drugs or lifestyle or both, the more effective your interventions are likely to be. So it's useful to know what your risk is, but again, a lot of people feel like, why would I want to know if I can't do anything about it? And hopefully we'll be able to show that perhaps you can.
Let me come back a little bit to the analogy with heart disease. Back when you were doing your work in the 70s and the 80s, at that time, the heart healthy diet said less beef, more chicken. Take the skin off your chicken. Less butter, more margarine. And you said, I'm not doing that. I'm going to go much further. And you not only had a more robust diet, I mean, you basically threw the cholesterol off the plate. And you added healthy lifestyle choices, but also a whole lot of support. So kind of giving the human animal what we need to be able to make these changes. And I was impressed by that at the time, but I'm also thinking that maybe, I'm wondering if that's not where we are today. Later on this afternoon, we're going to be hearing from Lisa Barnes, who was the first author on the MIND study that came out in New England Journal. And she's presented here before, and Martha Claire Morris, who started that study and was a great friend to us, presented here. But when they began the study, the idea was, it wasn't vegetarian or vegan, it was have more fish and have more blueberries and things in the context maybe of a not dramatically changed diet and changed lifestyle. And I was contrasting that where they had really negative findings. They came out very honestly in the New England Journal saying, this didn't get us to where we were hoping to get. Your intervention strikes me as going several steps further, both with regard to what the intervention consists of, but also the kind of support that you provide for people. Am I reading that right?
Sort of. I mean, they actually did have some interesting findings, which was that they were able to stop the progression. I mean, the study that just came out wasn't working with Alzheimer's patients. They were working with people who had a family history of dementia to see whether a more moderate intervention could do that. I mean, in the lifestyle heart trial, in our cardiac study, the randomized control group was following the diet that you're talking about that most doctors recommended at the time, the American Heart Association diet, or what was the National Cholesterol Education Program, Step 2 diet, less red meat, more fish and chicken, just the way you described it. And that was the randomized control group, and they got worse after 1 year and even worse after 5 years. And so clearly, whereas the people who made more intensive changes showed some improvement, some reversal of their disease after 1 year, even more reversal after 5 years, there was a 400% improvement in blood flow to the heart as measured by cardiac PET scans, which got worse in the control group, which was that we published that in the Lancet and in JAMA in 2 different papers. The Lancet, the 1990 1-year findings, the JAMA 1998 were the 5-year angiographic findings, and then in 1995 we published a paper in JAMA about the PET scan findings. So you're right, the more moderate changes don't go far enough. And I've been, I think the American Heart Association is doing, and certainly the NIH are doing amazing work. But in this one area, we just had a difference of opinion. They were saying, well, it's too hard to get people to make bigger changes. And I said, well, they are making it, but that's really a separate question. The question is we need to tell people what's true, not necessarily what we think is easy. We don't tell people, we know that nicotine is as addictive as, perhaps even more addictive than crack cocaine, but we don't tell people, it's too hard to quit. So just instead of smoking 2 packs a day, just cut back to 1 pack a day. We know you can't really quit, it's too hard. And I think those are very personal decisions. You know, you can make a case. Some people might say, you know, I'd rather eat what I want and live a shorter life. That's a personal decision. But I do think as healthcare professionals, we need to tell people what's true and not just what we think is easy. So, but anyway, getting back to your question about Alzheimer's, I think that the mind diet really came from Frank Sachs. And Frank is someone I have great respect for. We've been friends for decades. And we published a paper together, I think it was in the early 1980s, where we surveyed the people living in the Swami Satchidananda's ashram in Connecticut at the time, who were all vegetarian, and found that their lipids, their cholesterol levels, and so on, and blood pressure were much lower than you would expect in people who were not eating a diet like that. And so he tried to replicate those findings, and he had a hard time, again, getting people to make changes to this degree, so he modified the diet and came up with the DASH diet, and the DASH diet and the Mediterranean diet together kind of are the mind diet. And again, I think it's a great diet. It's a much better diet than what most people are eating, and maybe enough to slow the rate of progression, you know, the ounce of prevention, pound of cure. I don't think you have to make such big changes to prevent disease as you do to reverse it. That's why we were the first to show that in so many different areas in randomized trials, because people didn't go far enough. But, and in this study, they did find that these were older adults without cognitive impairment, but who had a family history of dementia, they were overweight, and they were eating a not a very good diet. And from what they found was that from baseline to year 3, the improvements in global cognition scores got better in both groups, you know, and I think in part because there's so much information that's getting out in the general public through the, you know, people like the Sherzais and others that, and that it's hard to have with a non-intervention control group. Even we found the last cohort in our study was starting to make, in the control group, was starting to make bigger changes just because there's so much information out there from, you know, from talks like this, for example. And so what they found was that both groups showed improvement in global cognition scores. The group that was on the mind diet showed a little more than the group that was not, but it wasn't statistically significant. So I think it's, you know, it's again a great testimony to the integrity of the investigators. But again, it shows that more moderate changes may be enough to stop the progression, or prevent the disease from getting worse, or from becoming clinically apparent. But to reverse it, I think if there's any chance of reversal, certainly based on what we found in our earlier studies. And by the way, I want to give a shout out to Jim Greenbaum, who I know is at your conference, for being one of the people who's helped fund these studies. These studies are very hard to fund because it's a bit of a catch-22. When you're trying to do something that's never been done before, it's a bit of a catch-22 because without the funding, you can't show that this crazy idea might work. And if they don't think it's going to work, like, why should we waste our money? And so all the studies that we've done over the years have been in that category. People thought were impossible at the time, which to me is what makes them an interesting question. But NIH tends to fund more incremental studies, you know, 500 milligrams of this drug versus 250 milligrams, you know, that sort of thing, not really disruptive ones. And so people like Jim and others like him who have the vision to help support these kinds of studies, just like the kind of work, the pioneering work that you've been doing, Neal, we're really grateful to.
Well, Jim is here today, and I'm sure he'll be grateful to have heard your comments. There are hundreds of people here in the audience now, and many of them are practitioners who are seeing patient after patient, and they hear what you just mentioned. Oh, well, maybe this is too hard, or that's the question in their mind. So how do you support patients in making a change? How do you help them to see that pathway forward and to get on it and to profit from it?
Yeah, well, the conventional wisdom is that small changes are easy and big rapid changes are hard. And you know, change is hard. Let's face it. You know, it's the status quo is always familiar and easy, and change can feel disruptive. Even good change can be stressful. But paradoxically, we often find that big changes can be easier than small ones. Changing your lifestyle, you know, a big change in your diet, for example, but also at the same time beginning to exercise moderately and meditate and spend more time with your friends and family and loved ones. Can be paradoxically easier. And the people go, well, that's crazy. I can't even get my patients to eat less red meat. You expect them to, like, you know, be vegan and exercise and meditate and love more all at the same time. There's no way people will do that. And yet we're finding that we're getting much higher rates of adherence and lifestyle change to a more intensive program than to a more moderate one. There's, to digress for a moment, after many years, when we published our findings, I thought that would change medical practice. And to some degree it did, but not nearly to the degree that I thought. And I realized that in order to change practice, you have to change reimbursement. That we doctors do what we get paid to do, and we get trained to do what we get paid to do. Not because we're only interested in money, but that's just how we learn. And so you do what you're trained to do. It's like, if the only tool you have is a hammer, as Abraham Maslow once said, everything looks like a nail. And so we're trained to use drugs in surgery. We reimburse to use drugs in surgery. Neal, you and I are on the American College of Cardiology's nutrition working group, and you and I published this paper with the other members a few years ago. The average doctor gets 4 hours of nutrition training a year. The average cardiology fellow in 4 years of fellowship gets 0. So I thought, well, if we could change reimbursement, maybe we could change that. And it took 16 years. That's a whole story in itself. But Medicare created a new benefit category in 2010 called intensive cardiac rehabilitation. And so we've been training doctors and hospitals and clinics and physician groups, and it's been working. And one of them was at UC San Diego, and Pam Taub there, a brilliant cardiologist, did a study comparing, because they were offering regular cardiac rehab, which is 36 hours of just exercise, compared to our program, which is 72 hours. It's exercise plus the stress management, the support groups, and the more intensive diet, and found that we got the much higher levels of adherence and much greater rates of completion to the intensive cardiac rehab program than the regular one. And people say, well, that's crazy. Again, you're asking people to do more, twice as long, much bigger changes. Why would that be? And the answer is that we found in all of our studies that the more you change your lifestyle, the more you improve at any age. When I started doing these studies, I had predicted incorrectly, as it turned out, that the younger people who had less severe disease would do better. But I was wrong. It wasn't, in the case of heart disease, it wasn't how old or how sick they were. The more they changed, the more they improved at any age. And every measure we looked at, whether it was the percent diameter stenosis, the amount of blockage in the arteries, or the amount of blood flow by PET scan, or the later studies, the PSA levels, or the telomere length, or whatever, gene expression, the more you change, the better you get at any age, which is a really empowering message to give people. Again, not to blame, but to empower, to say, your genes are a predisposition, but your genes are not your fate. We found that we published a paper with Craig Venter, who was one of the first to decode the human genome, that when you change your lifestyle in 3 months, over 500 genes were changed. And in fact, turning on and upregulating the genes that keep us healthy and turning off or downregulating the ones that cause us to get sick in just 3 months. You're not actually changing the gene, but you're changing those switches that turn the genes off and on, the methylation and the histone and non-histone proteins and sirtuins and things like that. And so, but if you turn off a gene that causes inflammation, for example, it's as though you've changed your gene functionally. And so again, knowing that, again, not to blame people. So when people say, even with President Clinton, and again, whatever your politics are, when a former president decides to make a big change in lifestyle like this, and especially one that was known for not eating so healthily to begin with, I think that sends a great message to everyone. But when his bypasses clogged up, one of his cardiologists held a press conference on CNN and said, it was all in his genes, his diet and lifestyle had nothing to do with it. And because I've been working with him for many years, I sent him a note. I said, it actually has everything to do with it. And think about it. If it was all in your genes, you'd be a victim. And you're not a victim. You're one of the most powerful men in the world. And so not to blame, but to empower. And so when you make big changes, most people feel so much better so quickly. It reframes the reason for making changes in lifestyle from fear that something bad might happen if you don't, like I might get a heart attack or a stroke or whatever, to joy and pleasure and love and feeling good. And that's what are really sustainable. Fear of dying is not sustainable. Joy of living is. I mean, we all know we're going to die. I mean, especially now that we both hit 70. I don't know about you, but just to digress for a moment, it really clarifies things. It's just like, oh gosh, I really have, as somebody once said, more yesterdays than tomorrows, but who knows if it's 140. But even then, time becomes even more precious. It's like I just only want to spend as little time as possible with people who don't, as my daughter would say, bring out my best self. But in any event, because of that, when you make big changes, fear is not sustainable. We know that we're all going to die. The mortality rate is, still 100%. It's one per person, but we don't think about it most of the time because it's too scary. Except when someone's had a heart attack or a scare, then they'll do pretty much anything that their doctor or nurse or dietitian says for maybe a month or two, and that's about it, because then the denial comes back. It's just too terrifying to think about that we're all going to die one day, so we don't. But when you make big changes all at once, if you have heart disease, your angina tends to go away. And within a few days to a few weeks, within 3 weeks, we found a 91% reduction in the frequency of angina in our studies. And so for someone who can't, walk across the street without getting chest pain, or make love with their spouse, or play with their kids, or go back to work, or do all the things that make life worth doing, and within a few weeks they can do all those things again. Or they find that these medications that they were told they'd have to take for the rest of their lives, their blood pressure and blood sugar and cholesterol-lowering drugs, among others, that under their doctor's supervision they can often reduce, and in some cases get off of these medications. They go, wow, I feel so much better so quickly that what I gain is so much more than what I give up. These changes are sustainable, not to live longer, but to feel better. Yeah, I may live longer, maybe I don't, but even if I knew I wouldn't live a day longer, the quality of my life is so much better. I have more energy, I think more clearly, my brain's getting more blood flow. There's Neal, when you and I were in medical school, we were taught that you got a certain number of brain cells, and if you went out and had a couple of six-pack and killed off a few thousand of them, you never got them back. We now know your brain is very dynamic as well, that within 3 months of just doing exercise alone, through a process called neurogenesis, you can grow so many new brain neurons, your brain can actually get measurably bigger, and even especially the parts of your brain like the hippocampus that control memory. Through a process called neuroplasticity, your brain cells can communicate better with each other. In early stage Alzheimer's, it's not so much that so many of the brain cells have been killed, it's more that they really aren't talking very well with each other. And so through neuroplasticity, we know that those things can get better or worse in both directions, and much more quickly than we had once realized. So the paradox in summary is that it's sometimes easier to make big changes because you feel so much better so quickly, it reframes the reason for making changes from fear of dying to joy of living. The other thing that makes it important is meaning. If you can ask people, why are you here? Well, I want to live longer. Well, why do you want to live longer? It goes, oh, I don't know. No one's ever asked me that before. We take it for granted people want to live longer, and yet the real pandemic, I think, in our country and so much of the world is loneliness and isolation and depression, with the breakdown of the social networks that used to give people that sense of love and connection and community. So telling somebody that they're going to live longer in and of itself, when I was suicidally depressed when I was in college, I almost committed suicide when I was 19. I was so depressed and lonely and isolated and cut off. I wrote about this in a couple of my books. And if you told, what I learned about being depressed is that you think you're really seeing things clearly for the first time when you're really depressed. It's a true reality distortion field. You think things are bad, they've always been bad, they're always going to be bad. Anytime you thought otherwise, you were just fooling yourself. That's where the sense of helplessness and hopelessness, you're a psychiatrist, you know this better than I do, but I do know it from my personal experience. So telling somebody who's lonely and depressed that they're going to live longer is not always that motivating. So I try to say, why do you want to live longer? They go, oh, no one's ever asked me that before. I don't know, I want to watch my kids grow up. I want to dance at their wedding. I want to, write a book. I want to, if you can help people find that sense of meaning, if it's meaningful, then it's sustainable. That's so important. And the third thing that really makes it work as well is the support groups. And again, they help us deal with that. They're not just helping people stay on the diet. They're a powerful intervention in their own right. And we create an environment that feels safe so people can let down their emotional defenses and open their hearts to each other and talk about how they're really feeling. And that's incredibly powerful in Alzheimer's disease especially because Alzheimer's is such a fundamentally isolating experience. You don't want to go out as much because you don't want to embarrass yourself, and then next thing you know, you're told you have Alzheimer's, and it's only going to get worse. Get your affairs in order. The best they can do is slow it down a little bit. That's it. If there's anything you want to do, do it now. And then, by the way, we're going to take away your driver's license, and so now your world shrinks even more. And so it just becomes a downward spiral for so many people, and in many ways self-fulfilling, because if you take people's hope away and their sense of meaning, then they just deteriorate that much more quickly. And so putting people in an environment where it's okay to talk about your feelings and to not just how, exchanging recipes and shopping tips and so on, but really talking about what's really going on in your life without fear that someone's going to reject you or or criticize you or make fun of you or give you glib advice or whatever. And it's the part of the program, the love more part, that people often have the most question or skepticism about. And yet invariably it's the most meaningful because it's something that's so, so powerfully needed. Vivek Murthy, the wonderful Surgeon General, who's a close friend, has made this the signature part of his tenure as surgeon, his second term as Surgeon General, is dealing with this loneliness epidemic. I think that, and it's important even in getting people to change their lifestyle, because so often when I ask people, why do you smoke and overeat and drink too much and work too hard and abuse opioids and play so many video games, these behaviors seem so maladaptive. And they'll say they're not maladaptive, they're very adaptive. They help us deal with our loneliness, our pain, our depression. I've got 20 friends in this pack of cigarettes, or food, fills that void, or opioids numb that pain, or alcohol or other drugs numb the pain, or working all the time distracts me from my pain, or video games distract me. So I've just learned that information is important, but it's not always sufficient. If it were, nobody would smoke. It's not like people don't know it's bad for them. We not have to only focus on the information and the behavior, but these deeper issues. And when we work at that level, we find that people are much more likely to make and maintain lifestyle choices that are life-enhancing than ones that are self-destructive.
I would like to invite members of the audience to come to the microphones and to ask you a question. Dean, would that be okay?
Of course.
Okay. While people are coming to the microphones, let me ask you a practical question. Should we get tested for ApoE?
Well, I think so, because there's enough evidence out there already that, including the recent MIND study, that if you're not currently symptomatic with dementia, but you're at risk for it, making lifestyle changes are most likely to be beneficial at the earlier stages of doing it. And by the way, these are lifestyle changes that are worth making anyway. It's not like, we're asking you to take a drug that's going to cause bleeding into your brain. These are lifestyle changes that are just going to make you feel better, and all the reasons that you've been talking about at this conference and throughout your whole amazing career. So yeah, I think because it's one thing to say, well, I don't know, maybe I should do this. It's another, if you find that you're at risk for something and you can do something about it, that can be a very powerful motivator.
Very good. Let's take a question from this microphone, please.
Sure, thank you. I'm a psychiatrist, been practicing for about 30 years. Appreciate your comments. I agree with all of them. It's heartening to hear a lot of things that you said, including looking at things at a cellular basis, getting away from when an organ system goes bad, but keeping ourselves healthy. And that's where all the things you talked about will come into play. And plant-based diet, obviously, so much benefit. Now, when it comes though to Alzheimer's and dementia, there also is a school of thought out there about the ketogenic diet and the possible benefits for that, and a lot of research, a lot of proponents for that. How do you feel about ketogenic versus plant-based, or a combination of the two? Do you have an opinion on that?
Well, I think that people tend to like to categorize things or focus on one aspect. Mm-hmm. And hyperglycemia, too much insulin, is a big part of our program as well. Our program is naturally low in refined carbohydrates and the kinds of things that cause blood sugar to spike and cause your A1Cs to go up. We find, just like Neal's done in his pioneering studies, that people who have type 2 diabetes get better when they go on a program like this, or like the one he recommends, which is not so, is very much the same. And so, yeah, the diet that I recommend has the benefits of a ketogenic diet, but we don't replace sugar with meat. We replace sugar with fruits and vegetables and things that have low glycemic indices and are rich in fiber. So you get the benefits of a ketogenic diet, but you don't get the toxicities of it. And so it's a combination. You're getting really the best of both worlds, because it's low in bad fats, it's low in refined carbohydrates and concentrated sugars, high fructose corn syrup and sugar and white flour and white rice and those kinds of things. But it's also high in fruits and vegetables and whole grains and legumes and soy products and things that are not only not bad for you, but have literally hundreds of thousands of substances, as you probably know, that have anti-cancer, anti-heart disease, anti-aging, anti-Alzheimer's benefits. And by the way, I meant to mention before that, in talking about the Love More part of our program, that Kim Williams, who was the president of the American College of Cardiology and went on a plant-based diet after reading our work, and has become a very powerful advocate of that, had a conference on lifestyle medicine at the American College of Cardiology's annual scientific sessions a few years ago. and Neal and I both spoke there, and I think I gave maybe the first lecture on love at the American College of Cardiology's meeting. It's one of those four-letter words that you really aren't supposed to talk that much about, and yet we are love-based creatures. That's what's kept us together as a species, being able to help each other. And to me, compassion and love and forgiveness are not only part of all spiritual traditions, once you get past the things that people fight over, but are really, in my limited understanding, the deepest parts of where healing can occur in the most powerful ways.
Great.
Very good. Thank you.
Thank you.
Question over here?
Yeah, thank you. This doesn't come from a medical professional, but my father currently has Alzheimer's, so I have a couple of questions. One, if I'm already addressing all of the recommended lifestyle things, is it worth getting the testing to see if I have the genetic predisposition for it?
I still think it is, because to reverse disease, whether it's, I mean, I can say this, publicly with heart disease or type 2 diabetes or prostate cancer or whatever, you have to make really big changes. They're not just moderate changes or a lot of changes, they're really big changes. And for many people, it's easier to sustain that degree of change if you realize that you're at high risk for something. Neal, in your diabetes research, you've kind of shifted away the focus from limiting carbs and focus more on animal products and oily foods and so on. Tell me a little more about that. I'm curious to know, what your thinking is.
Well, I have to say it's a bit of a challenge to talk with people with diabetes, and Dr. Kaliova, who's here. We kind of go through this every day, where patients come in with type 2 diabetes, and they have been hearing for decades that the problem was carbohydrate. And it makes sense, because when they eat carbohydrate, their blood sugar rises. But as Jerry Schulman and Michael Roden and others who have spoken here over the years have shown, that type 2 diabetes begins with insulin resistance, which is linked to the buildup of lipid inside your muscle cells and inside your liver cells. And so suddenly the patient has a completely different roadmap, which is, I need to get that microscopic fat stuff out of my cells. And when they do it, it's astounding. We're doing a study right now, and we tell our patients on day one, if you're on insulin or a sulfonylurea and you're now going on a completely low-fat, totally vegan diet, and you're really doing it, make sure you have your doctor's number, because you will get hypoglycemic if you don't start ratcheting down your drugs, but you don't want to do it without your doctor being in the game. They don't believe it. It's like, no, I don't think that would happen to me, because I'm never hypoglycemic. It happens very, very rapidly. So anyway, it's been an interesting thing to see, I have to say.
No, and again, we're in our program, we're also doing low refined carbs as well, so it's kind of getting the best of both. I'm curious, if I can ask you a question, Neal, that you've been doing this for low this many years. You've gotten like 175,000 members in PCRM, or maybe it's even higher now, and 15,000 doctors. You play the cello, you play the guitar and keyboards, you've been in pop bands. You've done so many things that you could be doing with your time. And this is really hard, all this is. I love that speech that John F. Kennedy gave in 1963 when he was announcing they were going to the moon. He said, we're going to the moon not because it's easy, but because it's hard. And this is sometimes what I tell people who want to change their lifestyle. Sometimes the things that are the most meaningful are the hardest, like having a kid. Most people would say, was that hard? You say, yeah, it's the hardest thing I ever did. Would you do it again? Oh yeah, like why? Well, because it's so meaningful. So I'm just curious if you could maybe talk a little about why you've taken on some of the most daunting challenges with animal rights, with litigation, as well as with doing good research. I mean, you're doing the work of like 4 or 5 or maybe even more full-time people. What gives you the motivation to continue doing such challenging work?
Well, thank you for that kind question, Dean. I'll answer briefly, but I want to make sure that the people at the microphones get a chance to ask you the questions, because that's what I'd really love to focus on. But I have to tell you, my own mindset really hit me a number of years ago that life is short, suffering is huge. Let's see what we can do to tackle it. Let's see what we can do to change things. And if you got some time left over, write a song, do something fun, do something nice, do something that's cool. But I have to say, Dean, I don't find this hard. I mean, you have to do work, but somebody working in a coal mine, that's hard. For me, I go to work every day. We have a fantastic team doing great work. And it's just wonderful to do. I mean, look at the team that's here. People going in the same direction, making the world a better place. Is this hard? It's great. And I got to say, you have been my role model for much of that time, Dean. When you were a medical student, tackling these really tough issues like reversing heart disease, sending your patients to Texas to get their scans, things that a medical student wouldn't think to do, but you did that. So good on you, Dean. I want to take a question from over here.
Hi, Dean. Thanks very much for the talk today. I have a question regarding an article or a study that was published in the Journal of Nutrition in May of this year that talked about the role of protein in mTOR modulation and amyloid deposition in Alzheimer's. And the study demonstrated that high consumption of protein correlated with a low function of autophagy, which protects from amyloidosis development in Alzheimer's. Have you looked at that as an opportunity for reversibility?
In other words, people eating too much protein had an increased risk of Alzheimer's?
Correct.
I'm not familiar with that study. Did it distinguish between the type of protein, whether it's animal or plant-based?
It did not.
Well, chances are, if they don't distinguish, it's probably animal-based because that's what most people eat. And it doesn't surprise me. It's just one more kind of piece in the puzzle and one more mechanism. Again, what I continue to put your question in a larger context, what I continue to be impressed by is how the more mechanisms we look at, the more reasons we have to explain why these lifestyle changes, including a whole foods plant-based diet, are beneficial. When telomeres first came out as a discovery, Elizabeth Blackburn published some papers with Alyssa Epple showing that people who ate a typical American diet or who smoked cigarettes or who were sedentary or who were stressed out, their telomeres got shorter faster. And I said, well, if bad things make them shorter, maybe good things make them longer. So we did a study and we found for the first time that in 3 months, the telomerase that regulates, repairs, and lengthens telomeres increased by 30% compared to the usual care control group, which we published in the Lancet Oncology. And then after 5 years, we found they actually got longer. This was the first study showing that anything could actually lengthen telomeres, whereas they got shorter in the control group. And when we published this, the Lancet editors sent out a press release calling it the first study showing that lifestyle changes may reverse aging at a cellular level. And again, now that I'm 70, that has more meaning for me. But the point is that I think autophagy and other mechanisms like that, as we're learning more about important roles they play, we learn how it just helps explain one more reason why diet and lifestyle changes could be so powerful.
Okay, thank you.
Question over here.
Yes, thank you for your talk. You've been inspirational. I've been teaching family medicine and integrative medicine for 40 years and 20 years, and you really led me there.
Thank you.
One of the things I use to motivate patients is I tell them I don't want them to lose independence, because if they had a stroke or a heart attack, their families would have to take care of them. And that's a big motivator. If they can't do it for themselves, they usually do it for the family. I do have a question, and that's if you do the genetic testing, do you counsel your patients or worry about potential limitations on life insurance or long-term care insurance if the industry finds out the test result?
Yeah, it's unfortunate that medical confidentiality is not as good as it could be. And so that is a real concern for some people. Or, there are some studies that have shown that, some people can commit suicide if they feel like they're diagnosed with Alzheimer's, not so much if they're at risk for it. So there are unintended consequences of knowing that. These are personal decisions that I think everyone needs to make. My brother, for example, didn't want to know. I mean, he had his genetic testing done and wanted to know everything but that. And even James Watson of Watson and Crick DNA was one of the first people to get his genome sequenced. He said, I want to know everything except the ApoE4. So, and a lot of people just don't want to know. But I do believe that if studies can come out showing it can be reversed, that it can give that much more impetus to people wanting to know. But there's already enough information out there, like from the current MIND study, showing that these things really do make a difference. And unlike most things we do as doctors, the only side effects are good ones.
Dean, let me jump in on that for a minute. I wonder if you've noticed this. You'll hear people say, I'm following a really good diet, I'm really doing as best as I could, but then they get some shot across the bow, a genetic test or some symptom. Suddenly you discover a whole lot of things you could do better. in your diet. You can clean up a lot of stuff that you were unaware of. I don't know if you've seen that as well.
Oh, yeah, and even more than if they find they're at risk, if they actually find out they have early disease, and now some of the, like the Alzheimer's tests, really actually show you that, you have really early disease, or some of the, the new CT angiograms that are non-invasive, you can actually pick up disease 10 or 20 years, sometimes even more earlier than it becomes clinically apparent. With heart disease, that's important because a third of people find out they have heart disease when they die from it, which is not a good way to find out. But telling somebody they're at risk for disease can motivate people to some degree. But again, fear is hard to sustain. But if you say you have early disease, if you keep doing what's caused the problem, it's only likely to get worse. If you make bigger changes, it's likely to get better. That can be a very powerful motivator.
Great. There's a question over here.
Yes, I have a question regarding, well, let's see, you talked about Alzheimer. Do you all look at the different type of cells, the astrocytes and the neurons, and the type of metabolism that goes on in both of them? And if you were to, do you also look to understand how the unfolded protein response system is not working and why it isn't working? I mean, you talk about nutrients, but do you ever tell people that the reason why those unfolded proteins that lead to Alzheimer is because you're not getting a particular type of amino acid, essential amino acid in your diet that prevent that sticking of the protein? Or do you ever tell them that why you have depression is because of the neurons and interneurons are not getting the essential amino acids that are needed to cause GABA to work, or as you said, learning requires dopamine, which comes from the essential amino acid. It seemed to me that if people want to improve their mental health, then they must fully understand the essential amino acid and the role they play within your neurons. You're not going to make serotonin without an essential amino acid. You're not going to make those inhibitory proteins without essential amino acids in the interneurons.
Okay, let's get a response from
Thank
Dee.
you. I appreciate your comment and your question. We can't measure astrocytosis and things like that without doing brain biopsies. Those are studies that are generally done in animals or in tissue culture, and I'm sure Neal would not want us to be doing those studies on animals, nor would I. At the same time, we are looking at a number of biomarkers that are more indirect measures of these things, whether it's the A-beta 42/40 ratio or changes in a number of other biomarkers that reflect that. And clearly, proper nutrition, including all the essential amino acids, are an important part of our work. We use some supplements as well. But there's no one thing in Alzheimer's or heart disease or any of these things. It's a amalgamation of all these things. And it's not even just diet, it's all these other things too. And so that's why we're trying to work on as many different fronts as possible. Now, the pure scientists who think they're the pure scientists would say, well, you have to have one independent variable, one dependent variable, you keep everything else constant. But when you do that, you miss the synergy that comes when you change a lot of things at the same time. It's not just additive, it's also often synergistic. And in many ways, that's why I think people didn't show reversal of disease before, because they would only focus on one aspect of it, and they didn't go far enough.
Well, I agree.
Very good. Let's take a question over here.
Thank you so much. Thank you, sir, for a phenomenal presentation. My name is Madhuri. I'm an endocrinologist at Baylor College of Medicine and work 100%.
That's my alumnus. That's where I went to medical school.
Yes, sir. Thank you again. And I work 100% at the VA. And in addition to encouraging all of my veteran patients to follow whole foods, plant-based diet, I have found myself more and more encouraging my patients about the importance of mindfulness and specifically mindful eating. Particularly for my patients that are the most extremely complicated patients with diabetes that are on insulin pumps and sensors. In so much so that I spend time with them in the clinic and we practice complete yoga breathing or resonant frequency breathing. My practical question to you is, how much time spent in mindfulness or mindful eating practices would you recommend to have a clinically meaningful impact?
You mean how much time do you need to spend with them, or do they need to spend?
That's a great question. I think both. I would spend as much time as, of course, I can in clinic, but how do I recommend them on a day-to-day basis? What's their practice method?
Well, the whole point about mindfulness is just paying attention, really. And again, because these biological mechanisms are so important, it doesn't really take time to do mindfulness meditation. in a way, because it's really a state of mind that you bring to everything you do. So when you eat something that isn't particularly helpful, pay attention how you feel an hour or two later. Generally, when people eat really unhealthy foods, they feel tired and sluggish and, want to take a nap, and because their brain's getting less blood and they're, all the kinds of things. When they eat healthfully, even a single meal, they can often feel better, or their chest pain gets better, or so on. So just connecting the dots between what you do and how you feel can be a very powerful teacher. And so then the symptoms become information, like your built-in teacher, as opposed to something terrible that we have to conquer. The whole language of the therapeutic armamentarium has this kind of warlike imagery, as opposed to saying, this is information I can use to be a motivator in my life. And just to digress a moment, I know we're getting closer to running out of time. When I was at Baylor, when I was starting my third year clinical rotations, I was on Michael DeBakey's surgical service. And he was one of the people who invented bypass surgery, and was a real tyrant, by all accounts. And he'd say, "What year are you, son?" I'd say, "I'm starting my third year." He goes, "Damn, it's going to be so much harder to bust you out of here with all these weird ideas you had." I'd already done the first study the year before, when I took a year off between my second and third years of medical school. He's the kind of person who would stick you and draw blood if you'd move your hands quickly enough out of the operating field, that sort of thing. Anyway, about 4 years ago, I got a call from him out of the blue. I hadn't heard from him literally in decades. And he had a very distinctive Louisiana accent that I recognized immediately after all these years. He said, "Hey, Dean, this is Mike DeBakey." And I said, "Hi, to what do I owe this honor?" He goes, "Well, those ideas that I used to give you such a hard time about when you were my medical student?" I said, "Oh, yeah, I remember really well." He goes, "That's what's kept me alive all these years." He said, I'm 99 years old. I'll be 100 soon. I'll probably die soon. I just thought you'd like to know. My wife got interested in your work, and it's really helped me a lot. So the point is that even things that are really hard and that there's so much opposition to initially, if you stay grounded in truth, if you do good science, if you don't overstate what you're finding, if you do your work with integrity, if you just hang in there, it is hard work, and yes, it's very meaningful, and I love going to work every day too, but it is hard, but it's worth it. Sometimes, as I get older, my event horizon just gets a little longer. Like I say, it took 16 years working closely with Medicare before they created a new benefit category. But then 3 years ago, they've been covering our program for reversing heart disease when we do it virtually. So now we can reach people in their homes. They don't have to live near a hospital or clinic. So now we can reduce health disparities and health inequities. We can reach people in rural areas or food deserts, wherever. Just, all they need is internet access, just like we're having this conversation today. So, if I give any advice at all, which I try not to do, is hang in there and don't get discouraged. Sometimes, meaningful change takes time.
Now, Dean, you just made everybody's ears perk up a little bit, because you mentioned that people can do this through telehealth. And telehealth has just transformed medicine in the past couple of years. If somebody wants to find out more about your program through telehealth, where do they go?
Oh, well, thank you. Yeah, we're now doing it. Medicare is covering it. Blue Shield of California, Aetna, and others are covering it when we do it by telehealth. If anything good came out of COVID, it was learning that we could do it by Zoom as well as in person. With our Alzheimer's patients, we were meeting in person, and then when COVID hit, we could no longer do that. And so I thought, well, let's just either shut it down or let's do it by and I thought it was too high touch to be done by Zoom, and I was wrong. It worked really just as well in many ways. And then that kind of opened the door that now we're collaborating with the heads of neurology at Harvard and Mass General and UC San Diego and at UCSF and Renown and others, where they're recruiting and testing the patients locally, but we do the intervention by Zoom, and it's working great with Alzheimer's. And it's working great with cardiac patients as well. So if you go to ornish.com, there's information about that. And for most people who have Medicare and Blue Shield and Aetna and so on, it'll cover it. And so now we can, for me, it's really meaningful, and we're grateful to Medicare, because if it's reimbursable, then we can get it to people who most need it. I didn't want this to be concierge medicine for just people who could pay for it out of pocket. That's why I spent 16 years with Medicare to work with them to get this. And now that we have it, and now that they're covering it virtually, at least for the next year and a half, and hopefully indefinitely, we can get it to people and reduce health disparities and health inequities and get it to people who can benefit the most. So thanks for asking about it.
Well, Dean, I have to say your research has led to your description of a unifying theory of disease, but I think you've today presented the unifying theory of healing. So thank you for that, Dean.
Thanks so much, Alex.
Thank you so much for being with us.